We now move ahead with the scientific session proper for the day 2 of GDBPCON 2023. The first session would be chaired by Dr. Amalraj, Senior Consultant Pediatrician from Chennai. May I request the first speaker of the day, renowned geneticist Dr. Sujatha Jagadesan, to occupy the podium for her talk on genetics in autism. I request the chairperson to occupy the dais and conduct the proceedings of the session.
Good morning, one and all. As we all know, autistic spectrum disorder is a slowly growing epidemic. No pediatrician will finish his OP in a single day without seeing any suspected child with autistic spectrum disorder. So there is a silently growing epidemic. So on this particular subject, we have 4 eminent speakers who are going to share their vast knowledge, starting from the genetics of autistic spectrum disorder to the therapeutic approach. So I welcome all the 4 speakers. And first of all, we have eminent speaker Dr. Sujatha madam. She needs no introduction. Over to you, ma'am.
The organizers for ensuing this wonderful conference. And without much ado, let us go to the topic of the day, genetics and epigenetics of autism. So as we all know, autism spectrum disorder is a heterogeneous group of neurodevelopmental disorders characterized by problems mainly in social interaction and communication and presence of repetitive and stereotype behavior. It affects around 1 to 2% of the population, and as we all know, there is a male preponderance, and it is genetically heterogeneous and may be caused by both inheritable and de novo variations. And we classically encounter 2 groups of children. One is the classical autism group, or the second is a part of a genetic syndrome or a condition. So autism, why does it happen? So there are 3 major categories which we are going to look into: genetics, the environmental influence on the genes, and the epigenetics. So the genetic etiology, when you do a test in a child with autism, you are able to identify a reason in around 25 to 35% of children, but this is on the rise as newer genes are getting identified. So when you come to genetic etiology, any child with autism can have a genetic basis as a cause. So what are the genetic etiology which we can consider? So it can be an error in the chromosomes. When you say chromosomes, it can be an error in the number or in the structure, or it can be a copy number variation, which refers to microdeletions and duplications at chromosomal level, or it can be a mutation in the single gene, which can be an isolated mutation or associated with syndromes, inborn errors, etc. Or it can be an error in the mitochondrial genome or in the nuclear genome, which controls the mitochondria. And then we come to complex inheritance like triplet repeat disorders and imprinting disorders. So how do you approach a child with autism for a genetic diagnosis? The first step is a detailed history. Then we do a 3-generation family pedigree and a detailed head-to-foot examination and anthropometry, evaluating the parents and other affected members in the family, fixing a syndromic diagnosis wherever possible, offering testing, both genetic and supportive investigations, and the proper interpretation of the results and an accurate genetic counseling. So this will be the flow chart of an approach to a child with autism. And what are the genetic tests that are available? So for chromosomal disorders, we have the karyotype, and then we have FISH, and we have microarray. And for single gene disorders, we have the clinical exome, we have the whole exome, whole genome profiles, and which can be done for the child, or we can do it for the child and parents, which is called the trio. And for complex disorders, we have the triplet repeats and the methylation testing. So what is the yield of genetic testing? This is a very interesting paper by Professor Harris. They have studied around 500 toddlers between the age 18 to 36 with the diagnosis of ASD, and only half of the subjects completed the genetic testing, and 12% had pathogenic findings, and they didn't find any clinical difference among children who had a negative result or who had a WOOS or who had a pathogenic finding in the genetic testing. But they could recommend a medical recommendation in response to the genetic findings in around 72% of children with pathogenic findings. So now coming on to chromosomal errors and autism, the chromosomes contribute to around 2 to 5% of the genetic diagnosis for autism, and 15q11 duplication is very commonly found among children with autism. There can be translocations, deletions, inversions, etc. And also sex chromosomal aneuploidies are known to be associated with autism, and Down syndrome has a 7% association of autism. So these are all examples of numerical aberrations. As you can see, there is only error in the number. So here you can see trisomy 21 where there are 3 21 chromosomes. Here this is an example of Turner syndrome where there is only one X, and here this is an example of Klinefelter syndrome where you have 2 X and a Y. So these are all numerical aberrations which can have an autistic spectrum attached to it. So when there are structural problems in the chromosome, so I am presenting a case history. This family came for a pre-pregnancy counseling. The first child had autism, and then there was voluntary MTP, and the last child, the index child, had autism with global developmental delay and significant dysmorphism. So this child became our prime focus because this classical dysmorphism was highly suggestive of a condition called Wolff-Hirschhorn syndrome, which is a 4p deletion. So when we did the FISH, we identified that there was 4p deletion, and then but the other there was an uncle. When you see the pedigree, there was an uncle also who had low IQ, the wife's brother, the mother's brother. So then when we investigated, those two members had 4p duplication. So one member has 4p deletion and the other two members have 4p duplication. So we went and did a karyotype which showed a 2 and 4 translocation. So in larger rearrangements, instead of doing FISH, if we do a karyotype, we can know the exact mechanism. Instead of just telling it is 4p deletion, we know there is a translocation between 2 and 4. So for prenatal diagnosis and for counseling, this becomes a great value add. So more than one test may be required to come to a conclusive finding. So how do you counsel? So child with a chromosomal abnormality, just see if it is numerical or structural. If it is numerical, the recurrence is low, we need not go and test the parents. Whereas if it is a structural chromosomal error, we need to do a parental karyotype, and if one of the parent is carrier, recurrence is around 10 to 15%, but if the parents are normal, the recurrence is low. Now moving on to copy number variations, there are small deletions or duplications across the genome. If you do a karyotype, we cannot detect these problems. So this is recommended as the first line of testing of investigation for an autistic child, and we have to go for greater depth testing. That is, we either choose 750K microarray or NGS based CNV analysis, and there are a lot of reported CNVs in literature. So this child, antenatal period was uneventful. Target scan showed a small cortical cyst in the right kidney, and it was a term vaginal delivery, cried well at birth, and postnatal finding was the same cortical cyst in the right kidney, and at 1.5 years the child developed features of autism. Initial motor milestones were normal, only speech delay, but now no response to name call. And when we did the pedigree, we found the paternal uncle succumbed to renal disease, father who is just 28 years diagnosed to have diabetes, and this child had subtle dysmorphism, prominent forehead, prominent ears and micronathia. So when we did the microarray, we found that there was a deletion in the chromosome. So we found whenever you have a microarray report, you have to see what is the loss. Is it a loss or a gain? And what is the chromosome number? Here it is chromosome 17. And what are the number of genes that are involved here? And whether it is pathogenic or a ooze. So here these are the number of genes in the deleted region. The chromosome deleted point is 17q1, 17 chromosome, q arm, 1,2 is the locus. And here we found a very interesting gene called the HNF1 beta. So this gene typically causes cystic disease of the kidney and maturity onset diabetes of the young. So the father has a diabetes and this child has a cortical cyst with autism. So we went and investigated the parents, and we found the father also has the same 17q deletion. And we did the ultrasound of the kidneys, and he had increased renal echogenicity and cysts, and his HbA1c was 8.2, whether the mother's investigations were normal. So this is a deletion which has inherited from the father, and these CNVs behave like autosomal dominant conditions. So the recurrence here in the next pregnancy is 50%, and we can do prenatal diagnosis by microarray in every pregnancy to avoid the problem. So this is another case, non-consanguineous couple. First child had features of Soto syndrome, which is a syndrome, overgrowth syndrome with macrocephaly, advanced bone age. But because the child had autism, though it is an autosomal dominant condition which warrants a gene mutation, we did a microarray because there was unusual autism association, and we found that in chromosome 19 at 3.2 locus there was a duplication. So this duplication presents exactly like Soto's. So this is a de novo duplication because parents were tested and found to be normal. So recurrence in the subsequent pregnancy is low, but then there can be germline mosaicism in either the father or mother. So we recommend prenatal diagnosis in subsequent pregnancies. So this is a non-syndromic ASD, 3-year-old male, second born to non-consanguineous parents, had normal motor milestones but speech delay and was hyperactive, diagnosed to have autism spectrum disorder. There was no dysmorphism. So as a first step, the Fragile X screening was normal, and then the microarray revealed that there was a duplication of chromosome 17, and every time you have to see whether it is pathogenic or VUS, and always when you find a microdeletion in the child, we have to test the parents. Here the parental array was normal. So how do you proceed when you see a pathogenic microdeletion? We need to check the parents. If the parents are normal, the recurrence is less than 1%. But if the parents have microdeletion, they can be symptomatic or asymptomatic, because all microdeletions and duplications don't have the complete penetrance. So there can be variable expression in the parents. Parents can carry a deletion or duplication, can be absolutely normal. So we have to be very careful during interpreting a microdeletion report, because we need to see whether it is pathogenic, whether it causes a known phenotype, and whether it has causative genes in that deleted or duplicated region. So the interpretation of microarray is very, very crucial. So now moving on to single gene disorders, there are a lot of single gene disorders which are coming to light recently because of the breakthrough in the exome sequencing. And a typical gene has exon and introns, as you can see here. Exons are the coding regions and introns are the non-coding regions, and whole exome sequencing sequences all these exonic regions, and whole genome sequences all exons and introns as well. So I will take you through a few examples of autistic syndromes. So this is a classical example of an autosomal dominant condition. A 2-year-old child was brought with speech delay, no eye contact. There was mild delay in motor milestones, had seizures, was on anti-epileptic drugs. And when we examined, there were hypopigmented patches, and we suspected diagnosis of tuberous sclerosis. So whenever this suspicion is there, we have to examine the parents. And the mother, she was asymptomatic, but then she had tumors in the brain. And when we did a molecular analysis, we found that she was carrying a mutation in the TSC2 gene. So there are two genes typically causing tuberous sclerosis. One is TSC1 and the other is TSC2. But most of the mutations we come across is in TSC2 gene. And most of the parents will have adenoma sebaceum on the face when you examine them. They will also have ash leaf macules, seizures, or renal angiolipomas. But some parents can be asymptomatic. So definitely we need to look at the parents whenever we encounter an autosomal dominant condition. So neuropsychiatric disorders are present in 90% of children with tuberous sclerosis, and autism is present in about 60. So in autosomal dominant conditions, you can see one parent is affected and he transmits to the risk is 50% to males and females. So there is no sex predilection, and de novo mutations are also possible, but I have been mentioning germline mosaicism is a factor which we have to keep in mind. So prenatal diagnosis is offered in subsequent pregnancies. So this is a child who was brought to us because there was speech delay and poor eye contact. Motor milestones was normal. Child was very irritable, cognition was low, and mother says the child was very hyperactive, difficult to manage. So she was having a fair complexion and a blonde hair, and we suspected a metabolic problem. So plasma amino acids were screened, and which showed very, very high levels of phenylalanine and altered phenylalanine tyrosine ratio. And molecular testing confirmed that there was a mutation in the phenylalanine gene. So it is an autosomal recessive condition. Here parents will not have any symptoms, unlike autosomal dominant, and they will be only carriers, and there is 25% chance of transmitting it to every pregnancy, and here there is no sex predilection again, males, females can be equally affected. And there is a diet modification which can be given to these children, and this child is responding very well to the diet modification. So there are many inborn errors of metabolism which can present as IEM, like your PKU, purine metabolism, creatine deficiency, urea cycle disorders, Sanfilippo syndrome, etc. Now moving on to the next inheritance, X-linked recessive. This is a non-consanguineous couple. First was a spontaneous abortion. Second child had ASD, improving with therapy. And third was a female child, normal. On history taking, from 7 years, the child has been having frequent falls. And on examination, there was calf muscle hypertrophy and Gowers sign was positive. CPK was 29,000. So we did an MLPA test. So usually we don't do whole exome sequencing for diagnosing Duchenne muscular dystrophy, because it is just usually because of a deletion or duplication in the gene. So an MLPA is a technique to detect these deletion and duplication. So this test was done, which found a hemizygous duplication in exon 2. Exon 2 means it is very proximal in the gene. So this is an X-linked recessive disorder where females are carriers, and 50% of females of this carrier mother will be carriers, and 50% of her male children will have disease, and 50% of her males will be normal. So in proximal gene mutations of DMD, autism is known to occur, and there are several publications. So DMD, a very common condition like Duchenne muscular dystrophy, can also present as autism. And coming on to the X-linked dominant condition, this is a female child, 8 years old, brought for speech regression and developmental delay. And at the age of 2 years, MRI was done, which was normal. EEG was abnormal and was started on anticonvulsants. So baby was suspected to have Rett syndrome, and they have done a mutation analysis elsewhere, and they found that there was no mutation, and they had included only exon 1 to 3. And when we examined, we found the speech and developmental delay and characteristic hand movement, and we had a high index of suspicion of Rett syndrome. So the Rett syndrome gene has 4 exons. And the first exon usually is not contributory, but the fourth exon is very contributory. So we did a reanalysis because there was high index of suspicion. So the deletion duplication turned negative, but then there was a heterozygous mutation in exon 4. So whenever we investigate for Rett syndrome, we need to see whether the lab is including the exon 4 in the analysis. Otherwise, if there is high index of suspicion, we redo the test, and especially if the sequencing is normal, we need to look for deletion and duplication. So it is usually de novo, and the germline mosaicism is a factor which we need to remember. Mitochondrial, this is a very interesting inheritance, because there is a bit of DNA in the mitochondria, and certain mitochondrial functions are controlled by the nuclear genes. So there is dual inheritance. If there is a mutation in the mitochondrial DNA, you have this typical mitochondrial inheritance where only females can transmit the disease. Whereas if it is a mutation in the nuclear gene which controls the mitochondrial function, you can have an autosomal recessive pattern. So you can have a dual inheritance in mitochondrial disorders. So we need to find out where is the error in which genome, and then accordingly the counseling and inheritance patterns and prenatal diagnosis will vary. And typically in mitochondrial disorder, it won't present as isolated autism. Usually these children present along with seizures, developmental delay, pain, fatigue, etc. So there will be added symptoms in mitochondrial disorders. So when the genetic heterogeneity is high, so when there are many genes responsible, many mutations are there, then, and when the clinical phenotype is also variable, the yield of genetic testing is going to be low. Whereas if you have low heterogeneity and a specific phenotype, the pickup by a genetic test is going to be very high. So genetic pickup depends on the heterogeneity of the genetic reasons and the phenotypic specificity. So variant interpretation, the test panel, because autism is to find out a genetic reason for autism is very difficult, we have to use only higher end testing. So the depth of sequencing should be very high, and the panel should cover all large and small variants, and mitochondrial genome, whether they are adding it to the whole exome or we have to do it separately, has to be considered. And report interpretation will come in these various forms. It can be benign, likely benign, variant of unknown significance, likely pathogenic or pathogenic. So we use different databases like ClinVar, Polyphene, Franklin, OMIM to find out the exact significance of the mutation. And in autosomal dominant conditions, de novo variants are more significant in autistic children. When there is no family history, no consanguinity, parents are normal, those children are likely to have de novo variants in their genes. And clinical correlation has to be done by an experienced person. And whole genome trio is now recommended in the Western world because it covers the exomes, the copy number variations, mitochondria, and sometimes triplet repeats. So one test for all. So that is the policy they are following in Western countries, but the cost still here in India is quite high to use that as a first test modality. Now going on to some rarer inheritance. So these are all non-Mendelian inheritance. This is called the triplet repeat disorder. So the genetic language is a triplet codon. So instead of like CGG, CAG, GAA, so in the gene, in the proximal portion or in the exon or in the intron or in the distal portion, there can be unnecessary repeats of these codons like a typographic error. So if you have to have only 15 repeats, there will be some 200 repeats or 300 repeats, and that is what is called the triplet repeat disorders. So this silences the gene and prevents the protein to be formed. So this is a couple who came for counseling as his brother had hyperactivity, no eye contact, lack of socializing skills and developmental delay. So when I took the pedigree, so this is the person who came for counseling. His brother had this problem, and then when you look at the family pedigree, his mother's sisters, they all had sons who had the same kind of clinical scenario. So then when we checked for Fragile X, we found that this boy had excess repeats, and his mother was also a pre-mutation carrier, and then we cannot detect this by whole exome sequencing. We need a triplet TP-PCR to detect this. So this is also an X-linked disorder, and carrier mothers can develop premature ovarian failure, and adults who don't develop Fragile X can later develop late onset Parkinson's disease in males. So this is very important information which we need to look at the family as a whole. And then the last group of imprinting disorders, this is a 3-year-old female who came with hyperactivity and language delay. She did not have any social anxiety and was overtly friendly. She, as usual, nowadays this is a fashion to order whole exome sequencing for everything. So we have to be a little cautious before ordering those tests. And this child also came with a whole exome report which said that she had a WOOS, a variant of unknown significance for spinocerebellar ataxia, and the phenotype didn't match. But on clinical examination, there was a suspicion of Angelman syndrome. So we did methylation studies and deletion studies and confirmed it as Angelman syndrome. So environmental factors, a lot of environmental factors are talking about. One is the viral infections, drugs taken during pregnancy, chemical exposures, etc. But collect as much as possible the antenatal history, but then there is no test to prove that this is the exact environmental cause that caused autism. But these factors affect those only with a genetic predisposition. So all mothers who are exposed to viral infection don't get children with autism, but they should have a predisposition, a genetic predisposition, and those mothers are getting the epigenetic modifications and they transmit that problem to the baby. So now looking at what is epigenetics, it is a heritable or acquired change in the gene expression without modification in the sequence of the DNA. So this is a change that occurs in the genetic code which modifies the gene expression, but when you test there won't be any mutation that is identified. So that is what is called epigenetics. It doesn't have a Mendelian inheritance pattern. So there are three basic mechanisms. One is the DNA is wound around the histones. So if there is methylation, the wounding becomes very tight, and if there is acetylation, the wounding becomes loose, and then you can, the transcription occurs easily. So, and then there is microRNA interference in the transcription, and there is DNA methylation. So these are the three basic mechanisms that cause epigenetic modification. So when a mother is exposed to various environmental factors, there can be epigenetic modification in her genome, which she can transmit to her baby. And that is the reason why children get autism. So there are epigenetic biomarkers. They studied the brains, the cerebrum, the cerebellum, the cord blood and the placenta of children who had autism, children or adults who had autism, and they identified a lot of genes in these tissues. So they are all called polymorphic markers. They are not genes directly responsible for autism, but they increase the predisposition to get autism. So they are all called epigenetic biomarkers. They have a very great potential. This is a group of children identified with ASD, as per the epigenetic biomarkers, they can be stratified, and each group can be subjected to a targeted therapy and for an early response. And also detection can be earlier, and regarding the age of detection can be much earlier, and intervention can be started much earlier for a better response. So these are all the future prospects we are looking at by using these biomarkers. This is all still in the research phase. And this is a very nice interesting paper which came out in 2020, which says that depending upon the mutation, we can give therapy to target that pathway, and we can get a response or improvement in the autistic children, symptoms in some children. And in 2 of the cases, they were able to give modification in the diet and also melatonin for sleep. And so this improved the quality of life in autistic children. And also the primary diagnosis comes to light when we do the genetic investigation, and so the primary disease can also be treated. For example, inborn errors of metabolism, we can institute a proper diet. So by genetic testing, we can treat autistic symptoms, we can treat associated symptoms, and we can treat a primary disease which causes autism. So how to go about? According to guidelines from various bodies, do Fragile X screening in all children, male children with autism. In female children, Rett syndrome screening is recommended. Chromosomal microarray is the first line of testing, and the reported pathogenic yield is about 10% for chromosomal microarray and 1 to 5% for Fragile X. And exome sequencing if all the above are negative, or when you suspect some syndrome or metabolic problem. And methylation studies, TP-PCR for triplet repeat are all recommended when there is a strong clinical suspicion. And the diagnostic yield depends upon your clinical suspicion and the variability in presentation. So what is the value of genetic testing in autism? The exact genetic etiology becomes known. You can predict the recurrence risk accurately. Prenatal testing becomes possible. Specific treatment can be instituted if any. And long-term outcome can be predicted based on whether it is genetic or non-genetic. And risk to the extended family members become known. And future research on treatment perspectives become possible. Alternative reproductive options for prevention of occurrence can be discussed, and also pharmacogenetics, which is an upcoming specialty, which also guides us in prescribing the right dose of antipsychotics for the comorbidities in children with autism. Thanks a lot for the briefing.
Thanks, madam, for the exhaustive description on the genetics aspects of autism, and also on your valuable insights on the various modes of inheritance, especially the epigenetics part, which is gaining much importance in recent days.